So, guys, greetings, and this is Dr. Evangeline Saptika. I want to start a series of to know your body. Like, I'm a general surgery resident, so the surgeries we do, I want to share them and what we do in a surgery and what is the preparation we make, how we diagnose a disease, how is a management, how we take forth, and how we proceed with the surgery, everything for each one separately. Just like knowing the body, knowing how our organs work. Yeah, I think it'll be interesting if you like to support. So, as the first one, before surgery, the first thing what we do is anesthesia. Anesthesia, they play a very important role in a surgery. Anesthesia and surgery go hand in hand, and before a surgery begins, anesthesia, they do the pre-anesthesia checkup. After giving clearance, only then a patient can be taken up for surgery. So this is what you want to know. Like, before any surgery, you will be advised not to have any food, that is known as nil per oral, NPO. So NPO is generally 8 hours for solid foods, and we have to avoid fatty foods, or heavy diet is not advised the day before the surgery. So for solid foods, it is 8 hours of nil per oral. For liquid diet, it is 6 hours of nil per oral. For breast milk, it is 4 hours, and for clear water, clear liquids like water, it is 2 hours. So generally we say the patient to not to have anything 8 hours before surgery, which is like usually the surgery will be planned the next day. So from the night, from the 12 o'clock, don't have anything. That is what we order the patient the day before the surgery as nil per oral, not to have anything before 8 hours before the surgery. So before going for the surgery, you should have seen, if you have undergone a surgery, you should have seen the anesthetist team visiting you and checking for adequate mouth opening. They make sure, if we are planning for a general anesthesia, if there is adequate mouth opening. Even if general anesthesia is not planned, if it is a spinal anesthesia or regional anesthesia, they usually check for the adequate mouth opening, whether endotracheal intubation will be feasible, is it easy, or it will be a difficult intubation, because anytime in the surgery, if it happens that we have to go for a general anesthesia due to any reason, so this is a protocol. They check for the adequate mouth opening. So adequate mouth opening, what do we see in adequate mouth opening? So we all know about tonsillitis. There are types of tonsillitis: palatine tonsil, facial tonsil, and many more. Adenoids is one, but tonsil we have many, and these tonsillitis can get inflamed. So when these get inflamed, we will not be able to do the endotracheal intubation. Endotracheal intubation is oral intubation. You should have seen a tube which is inserted through the mouth orally, and then as I said, ventilation is given. So to check for that, adequate mouth opening should be there. So this adequate mouth opening, and whether this is graded based on Mallampati classification is what we have for that. There are 4 grades in this. So you know the hard palate, when we touch the with the tip of the tongue, when we touch the roof, what we see is the hard palate is hard, and when we go back, what we see is a soft palate. So hard palate, soft palate is there. So soft palate is what we see, one thing. The next one, on the sides, what we see will be the facial pillars. Sides we see facial pillars, and uvula is what we should see, the thing which is hanging down. So facial pillars, uvula, and then the tonsil is what we see, is what we should see. If all these 3 are visible, it is grade 1 adequate mouth opening, and it's going to be an easy intubation. If we don't see the uvula, then it is grade 2, and this is also going to be an easy intubation, not a difficult one. If you don't see the If only soft palate is seen, then it's going to be a difficult intubation, which is grade 3. And if only hard palate is seen, we are coming friend, only hard palate is seen, then it's grade 4, and it's going to be a difficult intubation. So this is one grading which we'll have to know. And how understood is, there are about 6 grades, ASA grades in anesthesia, given by the American Society of Anesthesiology. There are 6 grades, which has to be this has to be calculated, and they give us ASA grade 1. This is how it's like an impression for a patient, that like, yeah, anesthesia diagnosis, anesthesia impression for a patient before taking up for the surgery. So what are these? ASA grade 1 will be a healthy patient, normal patient, young patient with no comorbidities. ASA grade 2, the patient is having comorbid conditions will be diabetes and systemic hypertension, bronchial asthma, these are cardiovascular disease, these are the things. So if the patient is under control, have you taking regular medication, then this will be ASA grade 2. ASA grade 3, the patient is having uncontrolled hypertension, uncontrolled diabetes mellitus, or a frequent exacerbation of asthma, status asthmaticus, asthma attacks are present. This is going to be grade 3. And grade 4, grade 4, if the patient is having very severe, if the condition is very severe, patient is under shock, septic shock. Shock is like, there will be blood pressure will be very low, pulse rate will be very high. This is how we identify shock clinically. It is a parameter, it is one of the parameters, I say. So if in those conditions, it is staged as grade 4. Grade 5, we have to operate the patient, there is no other go. Without operating the patient, it will be very difficult for the patient to survive. Like if the septic shock in trauma cases, or if there is any aortic rupture, like aneurysmal rupture in the aorta, abdominal aorta rupture, in those cases we have to do the surgery, no other go. That will be ASA grade 5. And ASA grade 6 is there. This is for the dead patients in whom transplantation, organ donors, so they will be graded as ASA grade 6. So this one is one thing which you should, it's good to know about your body. So, and this is before going with the starting end to the series, I want to talk about the anesthesia. So anesthesia before going with the surgery, it's going to be a series. So this is what will happen before the day of the surgery. Now on the day of the surgery, we are going to give anesthesia, and there is going to be types of anesthesia. They can opt for a general anesthesia, spinal anesthesia, or an epidural anesthesia. Epidural anesthesia is an added one. Regional anesthesia or local anesthesia. So local anesthesia, a surgeon himself can do, him or herself can do. Anesthesia clearance may not be required for a local anesthesia. For local anesthesia, we give lignocaine. You should have seen that white color bottle, and if it is with brown color bottle, that is lignocaine with adrenaline. That is known as lignocaine and adrenaline together. That is the brown bottle that will have in brown bottle. And that brown bottle with adrenaline should not be used at the end arteries. End arteries, where we have end arteries, is with the end like the fingers, toes, tip of the nose, lips, ear lobes, penis. In these areas, we should not use adrenaline, because this can cause ulceration, gangrene formation. So we have to avoid adrenaline in the end arteries, and we should know the size of the end arteries, as I just now mentioned. Percentage, do you want to know about the percentage? I don't want to make it a very study tutorial. This is not a study tutorial, just sharing knowledge and helping you know, and a simple recap if you are a medico. So this is all about 2% is bought for bupivacaine with adrenaline, without adrenaline, and lignocaine is 4%. We'll be using 4 mg per kg, and with adrenaline 7 mg per kg. If you use adrenaline, the benefit or the advantage of using adrenaline is that it helps to increase the duration of the procedure. The lignocaine effect, anesthetic effect, acts for a prolonged duration. So that's why we use adrenaline. And for bupivacaine, we will be using 2 ml per kg. with adrenaline or without adrenaline. So prilocaine will be 7 ml per kg, and with adrenaline, if we use prilocaine, it's going to be 9 ml per kg. And there is a formula to calculate it. The percentage, like how much we'll have to use. On an average, we should use around 10 ml of lignocaine. It depends on the body weight of a person. This is local anesthesia. Regional anesthesia is in one region alone. They will be blocking the nerve above, will be blocked. We have to be mindful of not injuring the artery during any nerve, like regional anesthesia, local anesthesia, especially regional anesthesia. Not injure the nearby artery. We'll have to be careful about it. Spinal anesthesia. Spinal anesthesia, you should be, this is what we give, cesarean section. Spinal anesthesia is given. It's usually below the level of the umbilicus. And high spinal anesthesia till T6 level we can give. In some cases, recently in a hospital for an laparotomy, we did a high level spinal anesthesia with superadded with an epidural anesthesia. Generally, then just now I realized it's at the T6 level, superadded with epidural anesthesia. Yes, so that's how it is. General anesthesia. So when we give these anesthesia, you'll know what is happening. You will be conscious. You will not lose your consciousness, except in general anesthesia. Next I'll talk about general anesthesia. But there will not be pain, and the muscle will be relaxed. Muscle relaxants also we give for spinal anesthesia. That's important. No, general anesthesia we give muscle relaxants. Okay. So in general anesthesia we'll give volatile agents. You will be inhaling something through the mask. There will be, what you're inhaling is an anesthetic agent. And also we use muscle relaxants, and to revive the reversal of the anesthetic agent, we have also got the reversal agents which will be given at the end of the surgery. So you want to know the drugs of what we use for anesthesia. General anesthesia, what we use as a muscle relaxant. What should we know before we give a muscle relaxant? What should we check clinically? And there is snoring. You know what is snoring? This is one condition which we check, anesthetists check. If there is snoring is because there is difficulty in breathing while you sleep. This is not your fault. You find difficulty while breathing. That's why you snore. And this is a question which will be asked by an anesthetist before a surgery, because this is to rule out obstructive sleep apnea, because a patient with snoring can have obstructive sleep apnea. If the patient is having obstructive sleep apnea, we should avoid certain drugs, or we should be careful and superadded. We should be ready with another reversal agents. That's why. So I think the video is getting pretty long, and if you really like the video and want to know more about your body, about surgeries, then help, you can share your comments. So this is for today. It's around 13 minutes video. Bye and with love. This is Dr. Evangeline Saptika, your surgeon in making. This is gonna be a series of Know Your Body. Bye.